Welcome back, clinical problem solvers. We were asked to see a 70-year-old man with gross hematuria. He had visible clots, but no flank pain, no dysuria, and no evidence of urinary retention. We'll be honest, we initially sent him to the emergency department, but did we really need to? They observed him, he never needed a Foley, and the bleeding was transient and self-resolved. At the end of this video, you'll learn when to, number one, send your patient with gross hematuria to the emergency department, how to confirm hematuria, and once confirmed, determine a key question. Is it glomerular or non-glomerular? Step one is asking a deceptively simple question. Is this really hematuria? The first fake out is bleeding that isn't urinary at all, such as vaginal bleeding, rectal bleeding, or blood from the skin or perineum. If blood isn't coming from the urinary tract, the hematuria algorithm obviously stops. The second fake out is red or brown urine that isn't blood. In these cases, both dipstick and microscopy, which makes up the urinalysis, are negative, and causes include medications like rifampin or nitrofurantoin, foods like beets or food dyes, and rarely acute intermittent porphyria. That's why confirmation with the urinalysis matters for gross hematuria. So let's discuss the urinalysis. Dipstick testing detects heme, not red blood cells, so it's very sensitive but not specific. It turns positive with red blood cells, which have hemoglobin, or when red blood cells intravascularly lyse and release heme. This is different than red blood cells making their way into the urinary system. This is free hemoglobin. Or myoglobin from rhabdomyolysis. A positive dipstick should always be followed by microscopy, because if microscopy is negative for red blood cells, then it's not hematuria, as it's very sensitive and specific for red blood cells. So now let's discuss microscopy. Microscopy involves centrifuging the urine and examining the sediment. And 3 or more red blood cells per high power field defines microscopic hematuria. Most labs use automated analyzers. Automated analyzers are great at counting the number of red blood cells, but can't assess the morphology. So if an automated test flags positive and there's concern for a glomerular cause of hematuria, then an experienced human like a nephrologist needs to review the sediment. For any significant bleeding that might occur with epistaxis, purpura, or hematuria, we should always pause and ask 2 questions. First, is the patient on blood thinners, including anticoagulants or antiplatelet agents? Second, what do their coagulation studies show, including INR, PTT, and platelet count? You see, anticoagulation can unmask bleeding, but it should never explain it away, and these patients still require a proper hematuria workup. Next, we ask whether gross hematuria means the patient needs to go to the emergency department. Remember that as little as 1 ml of blood can visibly discolor the urine. So color alone does not reflect severity. For this reason, the answer is often no. Gross hematuria is rarely a true emergency. I wish I had known that earlier in training. The main reason to send a patient to the emergency department is concern for obstruction, such as when clots or a stone causing hematuria also leads to urinary retention, anuria, or severe flank or abdominal pain, suggesting obstruction. So really, if there's obstruction, they must go to the ED. Hemodynamically significant bleeding from the urinary tract is rare, unlike gastrointestinal bleeding, where we quickly place 2 large-bore IVs. You may be asking, why is that? Because hematuria usually results from self-limited bleeding from capillaries and venules rather than arteries. And again, even a very small amount of blood can make the urine look dramatic. Nevertheless, you should always ask about symptoms of significant blood loss, including lightheadedness, dyspnea, or fatigue from anemia, which would prompt referral to emergency department. But odds are gross hematuria is not going to be hemodynamically significant. Our patient did have clots, but he was voiding, had no retention, and no pain. So while clots pointed to nonglomerular bleeding, they didn't necessarily mean he had to go to the emergency department. That was a learning point. Once hematuria is confirmed, the next question is whether the bleeding is glomerular or non-glomerular. This distinction matters because glomerular causes often involve a nephrologist, while non-glomerular causes often involve a urologist. Clues favoring non-glomerular hematuria include blood clots, macroscopic or gross hematuria, dysuria, flank or bladder pain, and bright red or pink urine. Among these, blood clots are the most specific for a non-glomerular source. Clues favoring glomerular hematuria include dysmorphic red blood cells, especially acanthocytes, red blood cell casts, albuminuria, acute kidney injury, hypertension, edema, and cola-colored urine. Among these, red cell casts and acanthocytes are the most specific. Importantly, glomerular nephritis is less likely to cause gross hematuria. Once we're confident this represents non-glomerular hematuria and the patient is clinically stable, meaning they're not retaining, the next question is where along the urinary tract the bleeding is coming from and what the most likely causes are. We'll cover this in our non-glomerular hematuria video, The Diagnostic Journey. And remember this, study a little bit today so you're better tomorrow than you were yesterday.
That's a wrap, folks.